Good morning. Welcome, everyone, to the American College of Surgeons Surgical Healthcare Quality Forum for Northern California. My name is John Ma, and I'm the president of the Northern California chapter of the American College of Surgeons. I'm also the chair of the University of California Office of the President Tobacco-Related Disease Research Program Scientific Committee, and I'm pleased to co-host this forum along with my colleague, Dr. Shelley Marks.
Well, thank you, John, and good morning to all of you. My name is Shelley Marks. I'm a general and laparoscopic surgeon at the Palo Alto Medical Foundation and the president-elect of the Northern California chapter of the American College of Surgeons. And just in the way of introduction, across the nation, there have been 14 previous ACS surgical health quality care forums that have been convened as part of the ACS Inspiring Quality initiative to create a national dialogue around surgical quality and patient safety. This national effort has now been brought to San Francisco to specifically draw on the key lessons learned from the Bay Area's emergency response to the Asiana Airlines accident this past July.
Dr. Marks and I are pleased to have assembled several of the surgeons who provided care on July 6 of 2013 so that we can hear their firsthand accounts, their reflections over the intervening 6 months, and their recommendations for the future. During today's summit, we'll hear of the successful stories primarily from the perspective of surgeons, also recognizing the invaluable contributions of the operating room staff, the nurses, the house staff, the medical students, the pharmacists, the nurse practitioners, administrators, radiology technicians, anesthesiologists, and the entire healthcare team that were involved in these very successful outcomes. We're also pleased that Assemblywoman and former Majority Whip Fiona Ma is here to share the perspective of elected officials and to explore solutions for the future coordination and regionalization of emergency care in the Bay Area. But before I show a few slides to provide a context for our discussion, we'd also like to express our appreciation to all of the first responders, the paramedics, the firefighters, law enforcement, airport security, administrators, and elected officials who were also involved in the successful care delivered to the accident victims that day. We honor those whose lives were lost in the accident by carefully reflecting upon the events of that day to identify what might be done differently to prepare for the future. On Saturday, July 6, 2013, a Boeing 777 airliner departed from Incheon International Airport in Korea. On board were 291 passengers and 16 crew members as the plane approached San Francisco International Airport from the south to land on runway 28L left. Nearly half of the passengers were from China. The others on board were mostly from South Korea and the United States, with some passengers from Canada, India, Thailand, France, Japan, and Vietnam. According to NTSB reports, at 11:28 a.m., the plane crashed short of runway 28L's threshold, and the landing gear and tail struck the seawall that projects into San Francisco Bay. Both engines and the tail section separated from the aircraft. The plane slid westward and came to rest to the left of the runway, 2,400 feet from the initial point of impact. About a minute later, a dark plume of smoke was observed from the wreckage, traced to a ruptured oil tank above the right engine. 2 evacuation slides were deployed on the left side of the airplane and used for evacuation. The slides on the right side of the aircraft deployed inside the airplane, pinning the flight attendants seated nearby. By FAA policy, the crew rushed to the aid of the passengers first. A massive combined and coordinated rescue effort to this no-notice event ensued. First response paramedics, fire department, airport security, Coast Guard, and law enforcement teams arrived to extinguish the fire, begin the rescue and recovery, and then entered the hull of the aircraft, where some passengers had to be cut free with pocket knives brought by the rescuers, as there were no sharp instruments on the plane in accordance with FAA policy. Finally, the flight attendants pinned to the interior of the plane were freed after the passengers had first been evacuated, this flight attendants having sustained severe spinal injuries. The incident had a major impact on traffic in and out of the airport, including getting patients to the various hospitals as the airport was closed for a period of time. 181 of the passengers were subsequently transported to 12 Bay Area hospitals spread across 50 miles as depicted on this map, having sustained a wide range of neurosurgical, orthopedic, vascular, intra-abdominal, intrathoracic, inhalational, and burn-related injuries. 49 had sustained serious injuries. 132 had suffered minor injuries. The remainder were uninjured. A variety of surgical procedures would be performed, and a lengthy period of rehabilitation for both physical injuries and psychological trauma continues for some. Our focus today is on the hospital-based response and treatment, and particularly to understand the surge capacity in this mass casualty incident. Fortunately, incidents such as this are rare, and one intent today is to understand why the outcomes were so favorable, what could have been done differently, and what might be prepared for in advance for a future incident, either here or elsewhere in the nation. The successful outcome requires efficient operations with emergency care providers, EMS, and helicopter transport, among many others. With that, I'll turn it over to Dr. Marks, who will introduce our first speaker.
Thank you, John, for that excellent introduction to today's topic. It is my great pleasure to introduce Dr. David Hoyt, who is the Executive Director of the American College of Surgeons. Dr. Hoyt oversees nationally and internationally recognized educational and quality programs for the college, including education and training for surgeons and residents, and quality improvement programs, including the Committee on Trauma, the Commission on Cancer, National Surgical Quality Improvement Program, amongst others. Dr. Hoyt's participation is particularly fitting today, as he is a trauma surgeon and was the former medical director of the ACS's trauma program. He also has served as the chairman of the Department of Surgery at UC Irvine and the vice dean of the medical school there. Also, Dr. Hoyt was awarded the college's highest honor, the Distinguished Service Award. It's with great pleasure I introduce Dr. David Hoyt.
Well, good morning, and I just want to start out by thanking John and Shelley for taking the time to put this together. I think this is a wonderful forum you're going to have today, and I really am pleased to be part of it. What I'm going to try and do is frame this in the context of quality programs in general as you get into the discussion of this specific event. What the college is doing this year is celebrating the 100th anniversary of really our beginning, and the focus has been on really quality programs. Now, if you look historically, you may not know this, but the American College of Surgeons really started accreditation of hospital standards in 1917. This went on to become what we now know as the Joint Commission. But from the very beginning, surgeons have been there trying to analyze what's needed to provide for appropriate care, and that's then led to the Commission on Cancer, the Committee on Trauma, more recently programs in bariatric surgery, breast centers, and the NSQIP program. And from all of this experience, we've learned several things. And I want to just go through these four elements, which really are our foundational elements of quality improvement. The first is that you go through a set of standard setting, ideally backed by research or consensus when research is not available, and you put forth what you think should be done. A trauma system is a great example of that. The next is to go through the actual building out of the infrastructure, and we'll talk about that briefly. And then the third is to, from the beginning, commit to measurement of performance, so that you are actually able to tell if you're doing what you say you want to be doing. And then the fourth is to subject yourself to external peer review. Well, for trauma, the standard setting actually goes back 40 years. And the infrastructure that allows San Francisco to have responded so beautifully to this major mass casualty event really is based upon the principles that are put forth in documents like this. This sets the standards. It tells you exactly what needs to be done line item by line item. And the current revision of this document is forthcoming this year. The second is to actually, again, build out the infrastructure. And for a trauma system, really it's a focus on all three areas of death. So those things that are considered a focus of prevention, those things that are considered a focus of the first couple of hours of intervention, and then those things that occur several days to weeks out. It's an organized response to injury so that it has to detail every element of a system, and it's really that commitment that you as a community, and again, that was a success in what we're going to hear today. It includes things like pre-hospital medical education, setting up pre-hospital systems, 911 communication systems, triage and transport protocols. I mean, it's amazing when you look at that map and realize that the casualties from this event were distributed to 12 different hospitals, probably, I would guess, in a matter of an hour or so following the event. That would not have occurred 30 years ago. And then it has implications for the actual definition of trauma centers and acute care facilities. Now, the third is something that is relatively new in medicine, and it's this commitment to measurement of performance. I think business has been doing this for a long time. Government is certainly trying to do this more and more. Medicine has just gotten into this business in the last 30 years or so. But the concept is shown on this slide. And this is a graph from what's called the NISQIP program in the top there. And what you see is the performance of a hospital measured against their peers. So that's several hundred hospitals grafted, showing their performance against some outcome. This could be infection rate. This could be prevention of DVT. It could be anything you want. And what you see on the right in red are hospitals that are performing less well than expected. And what you see in the left are hospitals in green, which are hospitals that are performing better than expected. When you give this data to hospital providers, surgeons, nurses, what they do is particularly if you're in the red, you say, I want to improve, and it drives the system. And in fact, we've studied 100 hospitals participating in the NISQIP program and been able to show that just simply by getting this kind of feedback data, that complications were reduced, preventable deaths were reduced, and it played out to about 1 complication per day in a 400-bed hospital. Now, this kind of data, you can see in the graph in the lower part of the slide, is now available for trauma patients as well. And the so-called TQIP program is something that is used on a regular basis in San Francisco as well. Now, in addition to data, having data to deal with performance, collaboratives are important. Working with other hospitals in a particular system, sharing best practice, learning from each other. And we've found this time and time again as we've gone around the country with this quality forum, that collaboratives come forth and are very proud of what they've been doing. And I think, again, this becomes a model for how we go forward. Finally, we're all struggling with this concept of high reliability. But in fact, it's now possible to define what the elements of high reliability organization are. There needs to be a leadership commitment. There needs to be a simple set of techniques to actually achieve your goal, either through a protocol or a checklist, that kind of approach. There needs to be employee engagement across an entire organization. You need to have data to inform performance so that you can constantly be stimulated by that data. And then there needs to be accountability. Really, you're describing a culture of safety. And to just give you an example, following these principles in the United States in the last 5 years, we have reduced bloodstream infection by 45% by following these principles. So this is achievable. There are systems in this country that are really reporting 0 events of infection or iatrogenic complications by following this approach. This is where the future of medicine is, and we need to help lead that through systems like yours here in San Francisco. Now, the culture needs to be there, and traditionally the culture has been focused on or some would interpret it as being focused on being punitive. It certainly can't be blame-free. But somehow, as we look at our performance and try and improve, we have to establish this trust that allows us to be forthcoming and willing to go ahead and improve. Finally, this is to me the uniqueness of why you have the elegant system you have in San Francisco for trauma, but the same is true in many parts of the country. It's true for cancer, it's true for bariatric surgery now. We're developing a program like this for children's surgery in this country. And it's that you commit to going through external peer review. If you think about it, that's what assures the public that you're doing what you say you're doing. And again, this is a principle that's behind these 4 principles that we've talked about. Now, as we've gone around the country and shared best practice in these communities, this is what we found. That quality improvement is the future of medicine, and I've tried to make that point to you. It's not the only thing that we're concerned about, and we could spend another day talking about cost reduction. But quality improvement is the future of medicine. Quality is measurable, and there are techniques that can be used. You have to use high-quality data to be able to achieve that. Quality thrives in a supportive culture, and just the fact that you're having this forum shows that your commitment to this and your trauma system is a wonderful example. Collaboration spurs innovation and higher quality, and surgeons must lead, not only in the operating room, but on Capitol Hill and in the classroom. And again, by putting forth this forum today, you're demonstrating your leadership. In a way, we're saying that we're redefining our sense of professionalism. And really, instead of being based on control and assertion of authority, which is what surgical traditions really were in the past, today we're saying we're going to base it on measurement and evidence and collaboration, and we're going to be accountable to the public. With that, I just want to end with a little video that tries to capture what we think is really ultimately the motivation behind this. And again, I want to thank you for the opportunity to be with you this morning, and thank John and Shelley for inviting me.
Thank you so much, Dr. Hoyt, and thanks for sharing that inspiring video. The conversation today about how to improve the quality of our emergency care and trauma systems could not be complete without the perspective of a policymaker. This is one of the reasons that I am so particularly pleased to introduce Assemblywoman Fiona Ma as our keynote speaker. After receiving her Bachelor's of Science from the Rochester Institute of Technology in 1988, Assemblywoman Ma completed a Master's in Taxation from Golden Gate University and obtained an MBA from Pepperdine University. She became licensed as a CPA in 1992 and served as the district representative for former Senate Pro Tem John Burton for 7 years while still maintaining her own private practice. Her entry into politics began in 2001 when she first ran and won election to the San Francisco Board of Supervisors in 2002. During her tenure on the board, she authored landmark legislation on behalf of women and minority business owners. She was elected to represent California's 12th Assembly District in November of 2006. She would later become the majority whip, as well as the first Asian woman to serve as Speaker Pro Tem in the history of the California legislature. A key success was her legislation to ban toxic chemicals known as phthalates in baby products statewide. This became the model for a federal amendment authored by Dianne Feinstein and was later signed into law as part of the Consumer Product Safety Improvement Act of 2008. Assemblywoman Ma completed the maximum of 3 terms in the Assembly in November of 2012. She's worked closely with UCSF Medical Center as a champion for hepatitis B testing and awareness and to increase access to quality health care. We deeply appreciate her attendance today to share the policymakers' perspective on strengthening the emergency response. Thank you.
Thank you very much. It is an honor and a privilege to be invited to share the elected officials' perspective into the regionalization and coordination of emergency medical services and hospital-based care. Dr. Ma asked me to highlight the opportunities for our state to strengthen the healthcare delivery system from a regional approach at a level beyond the capability of a single institution. When I was first elected to the San Francisco Board of Supervisors in 2002 to represent the Sunset District, which is the Outer Sunset District, there was an article in the local newspaper that basically said, in the event of a major earthquake, the Sunset District would be impacted most because of the sandy foundation, the soft story structures, and the close proximity of each house to each other. Needless to say, this article prompted me to take a lead in emergency preparedness, which I continued throughout my elected career. In addition, my husband is a firefighter with Ventura County, so understanding what our first responders do and face in such a large, no-notice emergency event has been very enlightening. Today, we are here to draw on valuable lessons in the delivery of emergency and trauma care after the Asiana Airlines accident on the morning of July 6, 2013. I'm here to give a brief account of what happened before the hospitals admitted injured passengers and give you a policymaker's perspective on strengthening our emergency response. San Francisco Airport is owned and operated by the City and County of San Francisco, but is located in and entirely and surrounded by San Mateo County. In 2013, San Francisco International Airport was the 22nd busiest airport in the world, as measured by passenger traffic. They operate 24/7, 365 days a year, as all of you do in the medical field. The San Francisco Fire Department is in charge of all the day-to-day emergencies that occur within the City and County of San Francisco, as well as at San Francisco Airport, where they have a full 24/7 incident command and control team that can handle fires, medical, and aircraft emergencies, and also marine rescues. In addition, since the water around the landing strips in the bay is very shallow, they have a swamp boat and floating sidewalks that can be used in emergency situations. When large no-notice events and mass casualties occur at San Francisco International Airport, there are 2 separate command structures that form and are supposed to work together simultaneously. One in San Francisco, called the North County, and one in San Mateo, called the South County. It should be noted that California EMS is separated into 58 distinct counties that operate independently and exclusively on a day-to-day basis. In a perfect world, there would be regional cooperation, training, and sharing of resources of response assets, since emergencies usually have regional impacts, but this is not what is happening today. On July 6th, there were 307 passengers on the Asiana Flight 214, which was a Boeing 777. At the impact, there were 56 ground ambulances, 2 large airport buses, and 2 medical helicopters called to the scene. First responders determined that out of the 307 passengers, 181 required emergency medical attention. The other 126 were ambulatory and were able to walk and/or run from the airplane and later triaged and released. Some in the medical community have asked how these passengers were dispersed that day. It was decided that the 181 patients would go to 12 regional airports, as Dr. Ma pointed out. The San Francisco Fire Department has a matrix of hospitals in emergency situations. In this case, the first 4 immediately critical passengers are transported to the level 1 trauma centers in the area, which are San Francisco General and Stanford Hospital. The dispatchers then poll the other regional hospitals on the list that can accommodate critical trauma patients and upload the list of hospitals to the field, where 2 patients are sent to each available hospital until the hospital group reaches a maximum capacity of 48 patients. Then EMS starts contacting all of the other community hospitals and transports patients according to capacity and medical specialization. The first responders tried their best to get a person's name at the very least. However, in the Asiana situation, most of the patients did not necessarily speak English as their first language, so it was very difficult to document accurately who the person was and where they were being transported. If they have time, first responders may be able to use a translation app on their phones, but sometimes it's not always possible. In this case, the first responders were not always able to properly identify passengers, which made it more difficult for local and overseas families to get information about their relatives. In the end, first responders were able to assess and transport all 181 passengers that required medical care to the 12 regional hospitals within 80 minutes. All other ambulatory passengers were escorted off the tarmac within 90 minutes, which is remarkable and impressive. There are a couple things that I learned about this accident and why it is different from others. 1, in traditional 911 calls, first responders normally focus on the event, for example, a fire. They respond and normally assess the casualties or deaths. In this incident, the first responders found themselves focused on the many survivors and their necessary medical response. 2, first responders are typically trained in exterior emergencies. I believe this is the first time that first responders had to perform interior attack procedures in a major burning passenger aircraft and had to cut survivors free from their seatbelts and get them off the plane safely. 3, we have instituted diversion at all of our San Francisco hospitals to avoid emergency room overcrowding. However, I'm glad to see that in emergency situations, diversion is suspended. 4, although we should have a helipad at San Francisco General Hospital, which I supported when I was on the San Francisco Board of Supervisors, helicopters can only accommodate 1, maybe 2 critical passengers, given the size and capacity of our emergency response helicopters. In mass casualty situations, we need a lot of ambulances and buses to transport passengers by ground. The U.S. Coast Guard did deploy 2 helicopters in this situation and transported 2 passengers to Stanford University. However, medical emergency helicopters have to take into consideration 3 things when deciding to transport a passenger. They need to consider the weather, the passenger's weight, and the amount of fuel they have, so thus they are limited in emergency passenger transport situations. I also learned that the U.S. Coast Guard operates on a different communication channel versus the local EMS. So they are also trained in basic life support versus advanced life support. 5, one area that needs further study is the safety of the current one-strap seat belts worn by commercial seat passengers versus the 3-point seat belts similar to the seat belts in all common passenger cars today. If you've ever noted on takeoffs and landings, the flight attendants wear a harness-type seatbelt. The pilots often wear the same harness-type seatbelts as well. Perhaps we need to look at all types of safety belts and figure out what is best for all passengers on the airplane. And 6, because this was an international flight, first responders, as well as many others at the hospitals, faced language barriers. As I mentioned, many patients were not able to be identified even by name, and HIPAA, the Health Insurance Portability and Accountability Act, cannot be a one-size-fits-all and needs to provide some exceptions for mass casualties so that patient tracking and reconciliation can happen faster than waiting for the Red Cross to arrive on the scene. For your information, I learned that the Red Cross is the only authorized and designated authority by HIPAA to do patient tracking and reconciliation. So to sum up, here is what I believe are some of the needs from the lessons learned from the incident. A, fuller cooperation and regional cooperation is needed between all stakeholders involved, including EMS in the different counties, the Coast Guard, Red Cross, and the hospitals. B, translation applications and/or translators on the scene and/or accident is needed, and also at the hospitals. And C, improved passenger seat belts given the newer and safer plane designs. The National Transportation Safety Board just had a hearing in Washington, D.C. on December 2013 last month. A full report is pending, and I look forward to seeing their recommendations shortly. As a policymaker, we need to hear directly from you. The media also needs to hear directly from you. Too often, people like me don't get a chance to participate in such a forum like today, so you need to be proactive and communicate directly with people like me so you can let us know what we should and could be doing to increase patient safety, save lives, and make your jobs easier. The medical director at the San Francisco Fire Department asked a very pointed question. How do we know if an emergency response is resilient? The answer? There should be no one individual hero. And in this case, I think the collective Bay Area EMS team did the best that could be done in this very complex situation. However, let me cite one example of how an individual or hero can affect our community when he shares his experiences and thoughts. 5 years ago tomorrow, there was one such individual, and I'd like to give him due credit. Danville resident and U.S. Airways Flight 1549, Captain Sullenberger, executed an emergency water landing remembered as the Miracle on the Hudson. We don't always think of pilots in EMS situations, but Captain Sullenberger made a conscious decision to land the airplane as close to the ferry terminals as possible so rescue vessels and ferries could immediately access the 151 passengers. The National Transportation Safety Board, NTSB, held a hearing on Tuesday, May 4th, 2010, and issued more than 24 safety recommendations related to the airliner. The NTSB was established in 1967 as the federal government's primary accident investigation agency for all modes of transportation. Since the NTSB was established in 1967, it has issued more than 13,000 safety recommendations, the vast majority of which have been adopted in whole or in part by the entities to which they were directed. Captain Sullenberger and a few other pilots and aviation experts have been proposing an NTSB-like entity to tackle preventable medical harm and combat the systematic issues compromising patient safety. Certain NTSB publications known as blue cover reports are used by pilots and airlines to drive safety and could provide a model that could be emulated for hospital accidents. I had the honor of meeting Captain Sullenberger last November 25th, and he is a gentleman. I thank him for applying his expertise to improve safety in the aviation field and beyond. Thank you all for your attention, and I and other legislators look forward to hearing from you. Please share your experiences and perspectives and recommendations with us so that we can act prudently and serve our community better in the future. Thank you.
Thank you so much, Assemblywoman Fiona Ma, for your comments today. We really appreciate your attending this quality forum. I appreciate the panelists all coming up, and I'd like to introduce them one after the other. We have 4 panelists today who I'd like to thank each of them for coming. They represent 3 hospitals here in the Bay Area, all of which had fairly intense exposure to the patients from this accident. I'd like to start on my far right with Dr. Tom Weiser. He is an assistant professor of surgery at the Stanford University Medical Center, whose clinical interests include trauma and acute care surgery. He trained in his residency at UC Davis and at the Brigham and Women's Hospital, and obtained a master's degree in public health from the Harvard School of Public Health, where he worked with Atul Gawande, completed a surgical critical care fellowship at Harborview in Washington. Seated to his left is Dr. Michael Huang, who's an assistant clinical professor in the Department of Neurosurgery at UCSF. He works predominantly at the San Francisco General Hospital, where his clinical expertise is in surgical treatment of complex intracranial pathologies, both for tumors and vascular lesions. He completed his residency in neurosurgery at Georgetown. And on his left, Dr. Randolph Wong, who was a general and thoracic surgeon at the Mills Peninsula Hospital, where he is also the chief of surgery. He completed his surgical residency in general surgery at the University of Arizona. And then immediately to my right, my former professor of surgery when I was a surgical resident, Dr. Peggy Knudsen, who was the chief of surgery at the San Francisco General Hospital and a professor of surgery at UCSF. She did her training at the University of Michigan and also did a fellowship in pediatric surgery at Stanford. She is the director of the San Francisco Injury Center for Research and Prevention, which is one of the first CDC-funded centers nationally. She is the vice chair of the Central Committee on Trauma, and is also on the editorial board of both the Journal of Trauma and the Journal of the American College of Surgeons. She remains active also as a civilian consultant to the U.S. Military Corps and is the only civilian trauma surgeon who has participated in the care of the wounded in Iraq. Welcome to all of you, and I'd like to start with Dr. Weiser.
Well, thank you very much for the introduction and for inviting us to be here. I'm going to give a brief overview of my experience as a surgeon at Stanford University during the time of the Asiana crash. Our preparations for the crash actually started, we've had, Stanford University has a policy in place and a whole set of structures around how we deal with mass casualty incidents. Now, we haven't had a major mass casualty in quite a while, but we constantly review and update our plans and implementation protocols. And we revisited our plans in the wake of the Boston Marathon bombing. So about a week after the Boston Marathon bombing, I had trained in Boston. And so I was talking to friends who had participated in the response to the Boston bombings. And I went back to our department and to our leadership and wanted and requested a re-review of our protocols for what would happen in a mass casualty event. And interestingly, mass casualty events aren't all one size fits all. They come in different shapes and flavors, and they provide challenges to an institution at multiple different, what I would call pressure points. So, for example, an earthquake would provide a huge flux of patients early on. Most of those patients may or may not actually need medical care at the time of initial presentation, but then over the course of maybe hours to days, as more and more victims are identified and present to the hospital, the response is a very prolonged response. That would be a very different scenario than, say, a shooter on a campus, where you have a huge influx of patients, all of whom need operative intervention very early, and the bottleneck may not be the emergency room, but the number of operating rooms you can scale quickly to accommodate critically injured, penetrating trauma patients. And so we reviewed all our protocols and identified a number of areas where we could potentially get stressed or potentially have bottlenecks in patient care. As it turns out, several months later, after reviewing our protocols, the Asiana crash happened, and we had an unusual opportunity to test how well our protocols were going to work. From the Stanford point of view, it was very interesting. We had 55 patients from the crash who presented to our trauma center. They presented quite quickly, starting with 1 to 2 who were flown by helicopter, and then ultimately with busloads of patients, up to 15 at a time, that would present at our emergency room. And we were able to rapidly identify patients who were critically injured, move them quickly either to the operating room or to the ICU, depending on their medical needs, and create mobile units essentially that would allow us to triage and evaluate patients while continuing our normal function in the emergency room. The emergency room, when we got a notification of this mass casualty event, was able to rapidly triage and clear a number of patients from the emergency room right away, so that they were ready for a big flux of patients. And the interesting thing for us was that we saw 55 patients. We admitted 11 patients to the medical center and another 7 patients to Packard Children's Hospital. So the vast majority of patients actually ended up being treated, evaluated, and released. So for us at Stanford, it provided a perfect stressor of the system without actually having us to overwhelm our system of care and response. In other words, we didn't overwhelm our surgical resources, we didn't overwhelm our operating rooms, we didn't overwhelm our ICUs, and we didn't overwhelm the capacity of the hospital itself, but yet, because of the massive influx of patients, we were able to test in almost a controlled way how well our system worked. I'm happy to say that our system worked quite well. We were able to identify patients quickly, get names and identification, medical record numbers to appropriate patients, and then do a re-review of the system that evening and then the following day as a debrief to identify what problems we had encountered as caregivers. We identified a number of issues that we're working on currently to fix. One of the issues was the patient identification system. At the end of the day, with 55 patients, as was mentioned, it was hard to identify and match names with IDs. We didn't have every patient had a medical record number. Because the medical record number is a randomly generated number, we didn't have a way to enumerate the number of patients that we saw. And so we had to go back through our hospital manifold, so to speak, and our patient list to identify each and every patient, rather than being able to quickly pull up on a computer and see in sequence every patient that we had seen, starting at patient, say, 1 to patient 55. So that was a system that we're now re-reviewing. The part that functioned very well for us actually was our electronic medical record. If we had to be reliant on paper charting, we would have had much more problem identifying orders that were written, the sequence of events, and the sequence of treatments that were provided for patients. Because we have an entirely electronic medical record that includes electronic order entry, we were very easily able to track patients, identify where they were located, and also identify all the treatment decisions that were made for each and every patient, despite the influx of patients that we saw. And I think at that point, I'll turn over to my colleagues, but we used the event as a way to reaffirm that our planning was appropriate and to identify small but important improvements and ways that we can provide better patient care.
Well, good morning. I would like to thank Dr. Ma and Dr. Marks and Dr. Hui for including me in this morning's summit. I'm honored and I appreciate the opportunity to share some of my experience and reflection on the medical response to the Asiana accident at San Francisco General Hospital. And specifically, I would like to discuss the response from the neurosurgical team and the challenges that we face as a subspecialty service. So for me, July 6th actually started off as an ordinary Saturday morning. In fact, I was not on call, but was at a birthday party with my 2-year-old when the calls first started coming in. The initial information, however, was less than concrete. In fact, the first report I heard was that this was possibly a cargo aircraft and not a passenger plane. However, the gravity of the information was quickly made clear, and I was coming to the hospital shortly after. For the neurosurgery service at San Francisco General, July 6, however, was already a busy day even before the Asiana crash. As a subspecialty, neurosurgeons provide specialty care for diseases and injuries to the nervous system. And we're also a relatively small subspecialty department with a small staff. And furthermore, because it was the weekend, it was only a streamlined team that was on service. So that Saturday, at the time of the Asiana crash, the neurosurgical team was already on their second emergent case of the day. The attending neurosurgeon, Dr. Guy Rosenthal, along with the chief resident, had already operated through the night on a traumatic brain injury patient and had just started on another case of gunshot wound to the head. So needless to say, additional resources were needed for a response to a mass casualty event. Luckily, Dr. Jeffrey Manley, the chief of neurosurgery at SFGH, was already at San Francisco General Hospital to assist Dr. Rosenthal, given the multiple trauma already present. As the news of the crash and the potential for multiple injured patients were confirmed, Dr. Manley immediately called in all the available neurosurgery attendings, including myself, and put the others on alert. In addition, several of our colleagues from UCSF also voluntarily offered to offer their assistance. And several of our residents, both junior and senior residents, voluntarily came into the hospital when they heard of the news of the crash through the media. As a subspecialty service, we generally rely on the emergency department and our colleagues from trauma surgery to triage and to identify patients with injuries to the nervous system. Furthermore, as an academic center with trainees, the information generally flowed in a very well-defined stepwise fashion, passing from intern to resident to fellow, and finally to the attending. With the rush of victims coming in, it quickly became clear that this traditional workflow was too cumbersome and too inefficient. Instead of leaving it to the interns to gather information and wait for that information to slowly trickle up to the levels where decisions can be made, the directives needed to come from top down. Interns and residents, instead of simply gathering information, should be executing plans that are that are directed by the attendings and the more senior residents. In order to accomplish this, we quickly focused on obtaining the most important and crucial information that will allow us to make our treatment decisions. And for us neurosurgeons, that key piece of information is a CT scan. Dr. Manley situated himself along with the radiologist in the reading room adjacent to the CT scanner and reviewed the images as they were acquired. He was then immediately able to convey that information and a preliminary treatment plan to the rest of us via text. And while we were lucky that there were only very few severe traumatic brain injury patients, there were multiple spinal injuries and spinal column fractures that required immobilization and some that ultimately required surgical fixation. Most of the victims also had injuries involving multiple systems, and collaboration and communication among the treating teams was crucial. Again, the traditional method of information sharing first at the training level before being reported up the channels was inefficient and a risk for generating mistakes, especially in such a complex situation. So instead, the information needed to be discussed collectively to allow for efficient and appropriate management decision-making. Therefore, all of the treating subspecialty services, including neurosurgery, orthopedics, plastic surgery, we all gathered with the trauma team, with the ED staff, and the radiologists, and we systematically reviewed every patient, and this allowed us to make clear management plans for every patient using all the available data and with input from all the treating services. And then the treatment plan were then immediately distributed to all the caregivers. Of the patients we evaluated on July 6, 16 patients had injuries involving the nervous system. Most of these were spinal injuries, and several required surgical reduction and fixation. For a relatively small subspecialty service, this rapid and effective assessment and treatment of a large number of patients should be considered a success. And our favorable outcomes were the direct result of Dr. Manley's leadership, the quick and proactive response by our staff, and the results of coordination among the different medical teams. And while our overall response was successful, there are opportunities for improvement. For one, the notification of staff, including attendings, residents, of a potential mass casualty event can be better coordinated through a centralized mechanism. The prompt dissemination of accurate information to key personnel within each department will then ensure adequate surge in the staffing numbers. This is especially crucial for a small department like us in neurosurgery, where every person is vital. And we were, again, very lucky that Dr. Manley was already on site and able to coordinate our response effort. Secondly, I think the establishment of a dedicated medical command center for the purpose of coordinating communication among the various medical services could significantly improve patient care during a mass casualty event. Our gathering of teams and subspecialties that was so crucial for the systematic review of our patients to develop comprehensive treatment plans was not prearranged, but it developed out of necessity. A designated medical coordinator with access to all available medical data at a centralized location using a dedicated method of communication could significantly enhance the efficiency of care delivery and prevent medical errors. A mass casualty event such as the Asiana accident is thankfully rare. However, it does provide a unique opportunity for us to not only reflect and to improve on our response in critical situations, but also to develop systems that will improve the delivery of care in our everyday practice. So thank you.
I want to thank everyone for allowing me to present the community hospital perspective on the crash. My unique perspective is that I watched the whole event kind of play out. My office is on the 5th floor of the hospital and looks right over the runway. So I was doing some paperwork and I looked up, I saw a big puff of smoke, dust, and that's when the plane had initially crashed. So I saw the whole thing kind of play out from the slides coming out, from the emergency response to the start of the fire. So the whole thing kind of played out right in front of me. Then I realized that I was probably going to be part of the action when the casualties hit our hospital. The theme of my overview from the community hospital perspective of the crash is communication, either good communication or the lack thereof. And I have 5 brief points that I want to touch on that when we went back and reviewed our experience, these 5 main points came up. The first point is communication amongst physicians. At a community hospital, we probably don't have the manpower available in situations like this that maybe many of the larger hospitals have. So we rely on volunteerism. We had a fairly recent experience with the San Bruno gas explosion a few years ago, and we learned the most important lesson that we learned from that sometimes there's too much volunteerism, the so-called too many cooks spoil the meal phenomenon. When the explosion happened back then, all these physicians just rushed into the emergency room. So we had more physicians than patients at that time. So when we went back and looked at that, we realized that, hey, not everybody needs to show up. So we had in place a mass email system. So as soon as the crash happened, our chief of staff emailed every physician and say, we know there's a crash, don't come rushing in, we'll let you know if we need you. I had 4 of my colleagues actually text me and say, hey, I'm available. A couple of them actually came in, went to the office and say, I'm here if you need me. Just text me and I'll come down. But it really kept the emergency room from getting clogged up. Second point is field communication. Overall, I think whoever made the decisions of the patients that came to our hospital did an excellent job as far as the number and also the severity of illness. The only criticism I may have is that the communication between the field and our hospital was essentially absent. We really didn't know how many people were coming to our hospital, and once they were sent, we were never told of the severity of illnesses or what type of problems they may have, so we could prepare for that. We had talked with other community hospitals, and they were told to be on alert, so they had their disaster plans in place. But we're never sent any patients, and we're never told that there were going to be sent any patient. So everybody was there, kind of waiting, and nothing ever happened. I also asked our ER physicians in preparation for this meeting if they knew who was in charge of triage, and none of them really knew. So I think that's something that we have to work on as a community hospital, knowing the protocol, knowing who's in charge of what, so communications would be better. The third point is the importance of communication with the patients involved in the crash. 90% of our patients that showed up were Korean speaking only. And just by luck, the neurosurgeon on call was fluent in Korean and actually flies that flight about 4 times a year, he told me. So as soon as he heard, and he happened to be in the hospital, as soon as he heard about the crash, he came to the emergency room and offered his services. And he and I would just go from patient to patient. He would ask all the questions in Korean, and it made for an effective, quick triaging of our patients. So as a result of this, we've set up at our hospital, whenever these mass casualties occur, that will have all portable phones available, and that are all dialed into the interpreter services. We also have a list of interpreters in the hospital every day, and we make sure that those people are available too. Fourth point is with regards to our electronic medical record. We found that it was a poor way of tracking groups of patients effectively. We weren't able to flag the patient as a victim of the crash, so it was hard when we went back to look at data to gather all the data and to interpret it. So our IT department now is working on a way of flagging patients in groups so that we're able to go back and look and learn from the data that we collect. The last aspect is communication with regards to the media. We kind of learned the shady side of the media through this. Our security systems were poorly planned around this, and we realized that afterwards. We had media coming in, posing as victims' families, and trying to get into the rooms and ask questions of the victims. So we are currently working on a plan of how to limit access to patients and protecting their privacy. Thank you.
I also appreciate being asked to participate in this forum. And I want to, first of all, talk about preparation, and particularly since we are here for the American College of Surgeons, to talk about what preparations are done on the national level through the college. And the first is what Dave Hoyt already mentioned, in that the preparation of a trauma center and the verification of a trauma center assures the public that we have the resources that we need to take care of injured patients, whether it's somebody that gets shot on the street here in San Francisco or is injured in a plane crash. So that's the first thing, and the college has really led this since 1950, as Dave mentioned. So San Francisco General Hospital is always prepared to take care of casualties. The second is that through the Committee on Trauma, we developed probably 10 years ago a disaster prepared course. And it was designed actually by the Navy surgeon who responded to the Beirut bombings. He happened to be there, happened to take care of mass casualties, and actually developed this course for surgeons that we've all had an opportunity to take. That course only goes so far, but at least it gives you some type of a background of what you might expect in a mass casualty event. And the third thing is a more recent program that was developed in collaboration with the American College of Surgeons and the American Association for the Surgery of Trauma that allowed civilian trauma surgeons to get involved with the care of casualties coming out of Iraq and Afghanistan. For the most part, this took place in Germany at the evacuation hospital. 200 surgeons volunteered to go over to Germany for 2 weeks at a time to help take care of the victims coming out of the war zone. How that helps you is that you actually see some of the most severe injuries you will ever see in your career, but you get an idea of how the military works as well. For me, I actually had a chance to travel in theater with the Air Force and spent a week down in Iraq. And in Iraq, there's a mass casualty event almost every day. So you do get an idea of what you need to do and respond as a surgeon. Does that get you there? Really not. you're never really quite prepared for what you're going to see. So on Saturday morning, July 6th, I happened to be the surgeon on call for the day. And what happens with us, as already has been mentioned, we are already in the hospital. We start at 7. We are rounding with the team, so we saw 45 patients that morning. We had already had 2 major trauma events happen before this, one of which went to the operating room with neurosurgery, and another one was admitted to the intensive care unit. At around 11:15, I got a quote-unquote courtesy call from the emergency department that said, oh, by the way, there's a minor plane crash at San Francisco Airport, and it's probably a cargo plane. You probably won't get anything, but you should just know it's happening. I go, okay. And about 20 minutes later, I hear that the disaster command center has been activated at our hospital. And then I knew it was for real. And the first thing I did was go next door to one of our partners who was still on from the night before. He was hanging around doing his notes, and I said, please don't go home. This could be real. And I walked downstairs to the emergency department, and there already were people coming in the door. So as already has been mentioned, what happened at the field was really not communicated with us. There were 6 people who were critical rolling it in front of me as I walked downstairs. There was nobody in charge. We hadn't had a chance to get triage there. And so the first thing you do in that situation is make sure your pulse is still there, because it is a little spooky. And then you have to divorce yourself from the chaos and try to take command. So you assign a team to each patient. I learned this from the military and said I had nurse practitioners in some of my rooms. I had surgical residents. I said, this one's yours, this one's yours. You only think about that patient and come and tell me what you find. So we did that for the first 6 very critical patients, 2 of whom within 10 minutes had to be transported to the operating room. Fortunately and unfortunately, it was a Saturday. I say fortunately because the whole operating room wasn't busy with the other 10 rooms running. On the other hand, we're not as staffed up on the weekends as we normally are. But people heard this way before we heard it. And so people were already coming into the hospital, which was very fortunate. We didn't actually have to call anybody. So as you said, your disaster plan for notification, calling people, knowing where they're at, we didn't have to do any of that. People showed up and did their job. San Francisco General saw 10 criticals, 67 total, and admitted 35 patients total. So we were pretty staffed up, but we didn't close down to trauma. We still accepted people that came in by ambulance. We never went on divert, and we continued to do our normal trauma things in addition to taking care of these victims. I want to highlight 3 things that were real challenges for us. First, has already been mentioned a little bit. We had no identification on most of these people. As you're supposed to do when you get off an airplane in a disaster, you don't take anything with you, right? Don't they tell you that? Leave your stuff behind. So they left, what did they leave behind? Their passports. So we had no way, we had Homeland Security come to our cafeteria. And they set up their shop, and they tried to clear people through customs because they hadn't been cleared. They didn't have any luggage, many of these people, so the Gap actually came in and gave people clothes because they had no, so the community really responded in very unusual ways. Even a cook came in to make, continue the cafeteria open 24 hours for the people that responded. The second thing that was a big challenge for us was we had some very severe critical patients with pictures metabolically that were very unusual, that we were not used to seeing. And we actually entertained the idea that these patients had had a toxic exposure. And we didn't stumble to that right away. And so that really, it challenged us a great deal. We actually did talk to the NTDB, we talked to Boeing, we tried to figure out was there something on the plane that these patients were exposed to. Was it the foam on the runways that they were exposed to? Because we know they were hosed down, and we didn't think about decontamination, which is supposed to be part of disaster. We didn't think about that in this particular episode, and I think that was an error on our part. The third challenge was the culture. This was an international event. It wasn't just a bunch of people in San Francisco where we share a lot of information. These were Korean and Chinese who have a different idea about what should be shared. And we were very careful with our media representatives of what we said, and even that to this community was too much. So we really learned that we had to be more culturally sensitive to what we said to protect the family's rights and the patient's rights. And so I think that was a big challenge. And the last thing I'll say is, although there's a lot of splash at the beginning and the media are out there waiting to talk to you for a week, then everybody goes home. And the patients are still there. I mean, we have had patients who have been in the hospital for 4 months. Finally, we have the last patient leave our hospital, but it doesn't go away. It's a big challenge to your hospital, all the personnel taking care of these people for a long time. And it's very important to allow them to decompress as well, because this is a critical event for all the providers as well as all the victims of the crash. And we learned that as well, that to be an important piece. So we learned a lot from this, and I appreciate the opportunity to share it.
Thank you, Dr. Knudsen, and to all of the panelists for your excellent presentations, as well as your efforts on behalf of the airline passengers. In 2012, over 400,000 aircraft movements transported nearly 45 million passengers through San Francisco International Airport. Concurrently, 8.4 million residents of the Bay Area received medical care from an array of community hospitals, clinics, regionalized systems of cares, and academic medical centers, 24 hours a day, 365 days a year. On July 6, 2013, the core missions and functions of these two systems intersected, with the EMS system playing the critical role in transporting patients between the two distinct settings. That a major airliner crashed with a less than 1% fatality rate is a tribute to advances in aviation safety and aircraft design, as well as to the strength of our emergency medical services, particularly in the capacity to absorb this massive surge in patient volume and complexity. Our nation has now witnessed multiple successes in the delivery of mass casualty care. Another example is the medical response after the Boston Marathon bombings. It is with great pride that we read of the heroism and life-saving treatments of our surgical and emergency medicine colleagues in Boston, of the Massachusetts General Hospital, and of the acute care surgery program at the Beth Israel Hospital in particular. The ability of those Boston hospitals to care for the surge of 200 extra patients is another testament to the quality and importance of emergency medical services. In a New Yorker article, Dr. Atul Gawande explained why he perceived the outcomes were so favorable. We should note that all of the patients transported from Copley Square in Boston to hospitals survived. The 3 fatalities were all pronounced at the scene. Atul wrote, "What prepared us? 10 years of war have brought details of attacks like these to our towns through news, images, and the soldiers who saw and encountered them. Almost every hospital has a surgeon or nurse or medic with battlefield experience, sometimes several. Many also had trauma personnel who deployed to Haiti after the earthquake, to Banda Aceh after the tsunami, and elsewhere. Disaster response has become an area of wide interest and study. Cities and towns have conducted disaster drills, including in one in Boston I was involved in that played out the scenario of a dirty bomb explosion at Logan Airport on an airliner from France. Dr. Gawande's reflections highlight the importance, as we've heard from our panelists, of system preparedness. Today's presentations and these firsthand accounts highlight 3 main areas where I believe future efforts should be focused. First is on the preparedness and coordination in the emergency care system across the continuum, from the site of the accident to acute and hospital care. Addressing the suggestions that our speakers have raised should be a priority for policymakers in Washington, D.C. and in Sacramento. Second, adequate federal funding of existing programs and a financial investment in future research in emergency care coordination, trauma systems, and regionalization is vital. And third, the leadership and expertise of the American College of Surgeons, particularly the Committee on Trauma, should be utilized to educate policymakers to understand the need to appropriate those funds in the Affordable Care Act to support the continued creation of designated trauma facilities and the development of ATLS. I'd like to touch upon each of these briefly. So in trauma surgery, a key principle emphasized to trainees is the importance of the golden hour, that first hour after an accident when prompt resuscitation, transport, and surgical intervention can be life-saving. Many of the themes that have emerged today have highlighted the successes and also the surprises from this particular mass casualty incident. The daily challenges of emergency department boarding and overcrowding must be addressed simultaneously as a massive surge of injured patients arrives. The core principle of preparedness becomes paramount, and effective teamwork and action to transfer patients out of the emergency department, to ensure patient flow through available operating rooms and ICU beds, and to activate call systems to provide for adequate staffing and to minimize fatigue are essential. Effective leadership is vital, particularly in crowd control and handling inquiries from the media. The Asiana crash also brings into sharp relief the need to improve medical air access via helipads to transport critically injured patients to trauma centers. Some of what we heard this morning highlighted the value of social media in verifying information, as well as rapidly requesting assistance and enhancing communication about the extent and numbers of injured patients. Also highlighted has been the importance of translation and interpretation services to obtain consent and to complete patient assessments, because many of the patients did not speak English. Currently, legislation in Sacramento is being introduced to strengthen interpretive services and should focus on the experience of the Asiana crash. A second effort. 8 years after the Institute of Medicine report detailing a national crisis in emergency care, many of the challenges of overcrowding and ED boarding and ambulance diversion remain unsolved. The successful outcome after the Asiana accident demonstrates what hospitals can achieve and accomplish working collaboratively in a region. The Affordable Care Act authorized $224 million to support existing systems of trauma care and to stimulate research into new models of innovation for regionalization and emergency care coordination. But the President's budget proposals from 2008 to 2013 to Congress have not requested appropriation of these funds. It's interesting because a trauma and emergency care bill, Senate Bill 1873, had actually been introduced by then Senator Obama in the 110th Congress in 2007, specifically with this intent. And portions, though that bill did not pass, portions were used in crafting the relevant sections of the Affordable Care Act. Since 2010, there have now been 3 transformative events in the fields of trauma and emergency surgery. First, the story of Arizona Congresswoman Gabrielle Gifford's amazing recovery catalyzed a positive perception in Washington, D.C. about the heroism and courage of emergency physicians and trauma surgeons. Second, the April 2013 Boston Marathon bombings provided a window of opportunity to yet again remind Congress and the President of the importance of continued research in trauma and emergency care coordination. The third event is the Asiana response we have discussed today. All 3 events reiterate the vital importance of sustaining our nation's emergency and trauma systems by investing in research and resolving the challenges identified in the 2006 Institute of Medicine report. As the crisis in emergency care has only intensified since 2006, President Obama should ask, and Congress should appropriate, the $224 million to fully fund the trauma and emergency medical services programs that are authorized under the Public Health Service Act of the Affordable Care Act. And for that to happen, we will need to harness the leadership and expertise of the American College of Surgeons. As we've heard this morning, the American College of Surgeons and its Committee on Trauma have been leaders in advancing trauma care virtually since the college's inception in 1913. Drs. Hoyt and Knudsen have highlighted the role of the ACS in designating centers of excellence for trauma, the certification of Level 1 trauma systems, the introduction of the Advanced Trauma Life Support Program, ATLS, the involvement in translating lessons from the battlefield to our hospitals through collaborations such as the Visiting Surgeon Program, and the efforts to develop a nationwide trauma system. Many of these programs were pioneered here in San Francisco. We should remember the long legacy of San Francisco General Hospital as an international leader in trauma research and innovation. More recently, the fields of the acute care surgeon and the dedicated emergency surgeon have emerged under this college's stewardship. I believe a similar opportunity exists to more fully engage our trauma and emergency care experts and heroes and make their efforts known more broadly so that we can collectively develop and implement meaningful new efforts to improve trauma care locally, regionally, nationally, and around the globe. These programs must include education, professional development, standards of care, and the assessment of outcomes. So in conclusion, America should be very proud of the first responders, emergency medical services, and healthcare professionals who have repeatedly risen to the challenges in Boston, Tucson, and San Francisco. I'm pleased by the number of trainees in attendance today. Perhaps new solutions will come from one of you in this room who will follow the inspiring path of Dr. Hoyt and our panelists today. It has been an honor for me to address you. I do believe that there is assembled the intelligence, leadership, and courage to solve the challenges facing emergency rooms nationally and worldwide. It all begins by coming together collaboratively, as we have done here this morning today, sharing best practices and recommendations to move the trauma and emergency care systems in the right direction, to reflect the new challenges that we face today. With that, I'd like to welcome back Dr. Marks, Dr. Hoyt, and Assemblywoman Ma to join us on stage for questions and answer. We have two microphones in the room, so please raise your hand if you'd like to ask a question, and Stacy will bring a microphone over to you. We really do wish to be respectful of the time and wish to have a thoughtful exchange, so the questions will be limited to 1 minute each. I'd like to start by asking to begin the panel. Having been a participant in the Asiana airline crash mass casualty response, and with your unique insights, what special requests would you like to communicate to our policymakers and elected officials, both in Sacramento and in Washington, D.C.?
I would say one of the most important things is, as you had mentioned, the funding and the continued funding of the trauma system. I think it's important, and the panelists have mentioned, that the day-to-day function continued even through the crash. So the crash highlighted and provided stress to the system, but in fact, every day we take care of injured patients, whether they're injured in interpersonal violence, in transportation crashes, falls, work-related incidents. And so this system is up and running and functioning all the time. And it just so happens that these events highlight what we're doing every day, day in, day out. And it only functions if we have this support, both the financial and intellectual support that comes along with funding from both the federal and both the federal and the state level. And in addition, that funding is really crucial for evaluating our response, evaluating the impact we have on patient care and on patients, and how we can make our system better. And so part of our job as trauma surgeons, as trauma centers, is to continually try and improve our care of patients, and we do that through our own process improvement, and we do that through the support of kind of federal mandates. So,
thank you so much, Dr. Weiser. Dr. Hoyt, do you have any additional thoughts about the federal solutions?
Well, yeah, I mean, we all look to the federal government to do everything, but the fact is you have in San Francisco what you have because you've solved the problem locally. So I think, the thing that we can look to at a federal level is hopefully the impetus to take what's best practice. And San Francisco, quite frankly, has been one of the leaders for 50 years, really, in trauma systems. Long before we called them trauma systems, San Francisco General and the EMS system in San Francisco was leading the way. And I think what the federal solution can be is to try and encourage that best practice and spread it, in particular in areas where there are gaps. So we know, because we are the United States of America, we have consistent gaps. And I think that's really what the legislative effort attempts to do, is to create seed grants to systems that don't have systems. It attempts to encourage EMS systems to work together where there are challenges in coverage and try and make this a uniform response.
Thank you.
Are there other specific resources that particularly those of you who work at the San Francisco General would think that would have been helpful on that day?
Well, I think to echo some of the comments already made, for us, identification of the patients, having not only applications or phones available for translation, but actually to have physical interpreters there in the hospital with us seeing the patient would have been very helpful, especially for neurosurgical patients where we need to very quickly assess their mental status and their underlying neurological function. That would have been a very useful asset.
Please stand and go ahead.
Let's go.
If you could tell us your name and where you're from.
I work for TPMG, the Kaiser regionalization. I find it I'm a surgical oncologist, I'm not a trauma surgeon, but I find it particularly intriguing that, I guess, so I'm going to speak up. I find it particularly intriguing that I think the most important thing you mentioned that was a problem was communication, which is the most important thing when we look at the entire medical field in terms of what works and what doesn't work. So my question would be, Dr. Hoyt, is there somewhere in the country, like you mentioned, a system that actually has solved that problem that we could learn from? But it seems like just the fact that EMS and the hospitals have different wavelength in terms of communication, physically and I guess in terms of not being able to communicate. Is there somewhere in the country where this problem has been brought up and solved? Do we know?
Yeah, no, it's a great question. I'd be interested in some of the folks that know the local situation. Usually it's a capacity issue. So if you're looking at cell phones get exceeded in terms of the system being able to serve it. If it's in terms of triage, the triage was occurring, but there may not have been enough time to communicate with individual hospitals, even though people knew that they were in a responsive mode. And so I think it's hard to come up with a particular solution. Every time you do what you all are doing, which is basically looking back and asking what worked well and what didn't, you learn something that can then be built in place. But communication is probably the biggest challenge we have in medicine, as you pointed out.
Mike Karch. Mike Karch from Manning Lakes, California. First of all, I applaud your efforts, the four of you who responded. Obviously, this course is fantastic to review. The International Red Cross, Committee on International Red Cross has a statement dating to the beginning of the textbook that says each new generation of surgeons needs to relearn, keywords relearn, the art of disaster and war medicine. So my question to Dr. Hoyt and Dr. Knudsen is, what are we doing at the medical school level and the residency level to teach mass casualty? And the corollary to that question is the military, as I think Dr. Knudsen identified, has a very workable model. And the model is that the surgeon, the nurses, the techs train as a team as a group. And so what are we doing at the academy level, not just to teach surgeons,
I'll take a crack at it. On the mass casualty disaster, there was a disaster committee in the Committee on Trauma in about 1992, and they actually shut themselves down in 1998 because there was nothing to do, if you can believe that. And then 9/11 occurred, and everything changed. And the surgeon that really Peggy alluded to that stepped up and really led what surgery has done in terms of creating mass casualty courses has, I think, created something that's very important, and that's how people are currently being trained, including medical students and residents. There's a very interesting development that's occurring based on really the 10 years of war that's gone on, and that is that the military is taking a look at themselves as they start to wind down and become disengaged. How are they going to preserve what they've learned, how are we going to be able to accept a mortality rate that we're ending with going forward and not have to sort of recreate lessons learned. This is something that's occurred after every major conflict in the last 100 years. And for the first time, we're engaging in a conversation with the USIS Medical School, with the Department of Defense. Dr. Knutsen's been involved in this. And I can't tell you what's going to come of it, but we're talking about developing a strategic relationship with the Secretary of Defense and the American College of Surgeons to try and help come up with innovative ways to preserve readiness, to maintain training, to look at educational programs that might help sustain that readiness so that the lessons learned are not quite as, don't decay quite as much as they have in the past. Maggie?
Yes, we're very excited about the potential to continue collaboration with the military at our society level, at the local level. I actually just came back from Tripler Army Hospital, spending some time there, and what they want is continued presence of trauma for training for the military, because as soon as the war is completely over, then trauma goes away for them. And what they want is those of us that do trauma every day to come and make sure trauma stays on the agenda for the military medical schools and their trainees. In terms of team training, we haven't done very well, I don't think, at the in the civilian community of cross-training is really what you're talking about, so that when you go into a trauma room, you can play any role. You could be the nurse, you can be the team leader, you can be the person who does the running. We haven't done very well. We have done some simulation training where we've tried to do that, but we have a long ways to go still.
Dr. Weiser, any thoughts about Stanford University and how they might participate?
So we do run team training exercises. The problems with team training are difficult because logistically, and it's a huge amount of resource, and it's a big time commitment for nurses, for residents, for staff. But it's critically important, and we just need to make it a priority if it's truly going to be part of the system of education. With respect to the ongoing skills, maintenance of skills, both for managing trauma patients, but also for managing, multiply injured patients all at once. It's difficult because it happens unexpectedly. It happens in places that are unpredictable. And our best experience recently has really been the military, and I think that the program that Dr. Knutsen and the ACS have been involved with surgeons going to Landstuhl and being part of the war effort and the recovery of injured soldiers is tremendous and a huge experience. And I hope that we don't lose that experience. But it also demands that kind of conflict continually goes on so that we can keep that training. It's very difficult. It's very difficult to balance those two because, yeah.
Exactly. Other questions from the audience?
Hello. My name is Dr. Daniel Turk, retired Kaiser plastic surgeon. I'd like to ask Dr. Michael Wang if you think that three-point seatbelts might have prevented some of the severe spinal injuries that you saw.
So that's a very interesting question. I think whenever we board an airplane, when they go through their, emergency procedures and whatnot, one of the things they always tell you is in the times of emergency landing, you're supposed to lean forward and, put your body close to your knees. I think I think that's in some ways an attempt to eliminate the hyperflexion injuries that you see with only a lap belt restraint. The most severe, we did see the most of the spinal injuries that we saw were ligamentous injuries in the posterior column that were most likely a result of these hyperflexion situations. But the most severe spinal column injuries and spinal cord injuries that we saw were actually involved with the flight attendants who actually got pinned and therefore were not due to the seatbelt issue. But I do think that at the very least, you will eliminate, having a 3-point restraint would eliminate the possibility of these ligamentous injuries in the passengers.
Dr. Wu?
Russell Wu. I'm entering my 5th year of retirement as a general thoracic vascular surgeon, and I'm here because of concern for the city of San Francisco. When 911 happened, I looked out the window and I looked at the Transamerica building and thought, are we prepared medically? And I can say that I didn't think we were. I was at CPMC at that time in Chinese Hospital. I'm not sure how much more prepared we are now. This is a superb panel. It's well defined as a trauma unit, San Francisco General, Stanford Hospital. There's a city replete with private hospitals that are not prepared. What's changing recently is specialization. General surgeons are becoming rare. They're breast surgeons, endocrine surgeons, pediatric surgeons, and the general surgeons have been the backbone of disaster planning. I think there needs to be more regional cooperation. The concern about the various hospitals and their disaster planning. You're talking about what they can do legislatively and federally. There's JCAH, which everyone hates, but everyone welcomes when they're outside of this country. I'm not sure if they do it or not, but they should check, besides all of the minutiae, whether or not hospitals have a disaster plan. That's not just sitting up on a shelf in the administrator's office. And that it's hard to get people to plan and have drills and such. Time is of concern. But I think that you on the panel there are the leaders, and I think that much of what you have to say needs to go outside of this room.
Perhaps Assemblywoman Ma, you could speak to our preparedness as a city in general for tragedies such as have been mentioned.
Yeah, well, I know like our firefighters, our police, even our sheriffs, they do prepare a lot. They do have training and planning, and they try to work together in San Francisco. I think what I see as a disconnect is that although San Mateo and San Francisco now are debriefing over this incident, I don't know whether they're debriefing with all the hospitals to better prepare for the next emergency. So I think having this session videotaped, being able to share this with the other EMS providers at the forefront, the ground level, before the hospitals get the patients, I think is going to be very, very helpful from today. I see the disconnect clearly, and I think we can learn from this how to work better regionally, but also from the first responders to all of you and what the needs are and what's missing.
Other questions from the audience? Please stand.
Hi, my name is Vivian Reyes, and I am a member of the board for the American College of Emergency Physicians in California. I work for Kaiser Permanente in the emergency department here in San Francisco, and I also lead the regional mass casualty incident surge planning initiative for Northern California. So my question is about triage, and it might be best for Dr. Knudsen. Now, I know that the College of Surgeons had developed a SALT triage protocol for mass casualty incidents, and my understanding was that this was in an attempt to nationalize and standardize mass casualty triage in the US. So I wanted to find out where you are in that process. Are we still moving forward with that, the SALT triage? And also I wanted to know if you think that would have changed anything in the Asiana event.
I'll let Dave address the national issue, but I actually think they did a phenomenal job with triage for this particular event. The sickest patients, the most critical, went to the correct hospitals. And I actually have said that publicly on the media. I think they did a phenomenal job. There is that golden hour, and there were some very critically injured patients who truly had, if they had gone to the wrong hospital, I don't think they'd be alive. So I think I actually complimented the EMS agency and the firefighters for all they did, because you can imagine what that scene must have been like for them. And to have only 2 immediate deaths, and to transport the most critical patients, and I'm talking people whose blood pressure was not measurable when they came into our emergency department, that were in our operating room very quickly. And I think probably, Tom, you saw a couple of the most critical. They did a great job. I don't know about the national stuff.
Well, as you well know, the model for triage came out of California. It really did. It came out of the fire services over 35 years ago. And the concept of incident command, which is, that is established through protocol as to who's in charge, and then subsequently triage and transport is a derivative of that. The problem that led to some recent discussion was really highlighted in Newtown, where the concern in reflecting in that mass casualty incident is that, quite frankly, all the children were dead. And the concern was there adequate time to get in for those that were potentially survivable, based on the fact that it wouldn't be typical that everybody would have died. That was the concern. That was looked at very carefully, and some incredible leadership was provided by Len Jacobs, who was involved in this in Connecticut. But what came out of it was really a discussion that I think is very important, and that is that we helped Len put together a consensus panel that's now called the Hartford Consensus. And the people that were convened included Homeland Security, the FBI, Secret Service, et cetera. So all the people that would be regionally involved in establishing protocols for incident command. And the discussion focused on when you have a hot situation, so there's still risk to providers. Is there a reasonable way to renegotiate, sort of just waiting until all the shootings stopped, or however you want to define that, so that EMS providers can get in and take care of patients? And you can appreciate all the subtleties in that discussion, because it's been very controversial. But this document that they put together, and we'll be glad to get it for you, and then the operationalization of it through both the FBI and Homeland Security has occurred actually in record time, in about 6 months. The Newtown event was in December of 2013. This was published, and it's been operationalized just in the last several months. So that's really what that issue is. I don't think that would have changed how you would have triaged in the Asiana crash, but it would potentially in multi-casualty penetrating situations.
Thank you for that question. On behalf of the American College of Surgeons, I really wanted to thank you for being here on behalf of ACEP, and really to feature the important and valuable contributions of emergency medicine providers. We had wished to include a member of your discipline. Because of space limitations, we weren't able to do so. I was wondering, do you have any reflections from the field of emergency medicine? Feedback, perhaps, for the surgical?
Well, first of all, I just want to say thank you for putting this together, because I agree. I think that collaboration in this field is huge. And typically, for emergency management, the people who are visible are the emergency physicians, just because I think our schedule lends itself to it. So it's often hard to get the surgeons, to help with actual planning, because your schedules simply are just busier than ours. So being here and discussing this and getting your feedback and participating in all of this planning is really amazing. So I just want to say thank you for putting this together, and I really hope to work with you in the future. And as far as an emergency physician perspective, I think it was a really good learning opportunity. I think that San Francisco General did a fantastic job. I know some people from Stanford as well, the emergency planner there, and Dr. Weiss as well. So it sounds like it was a surge, but it wasn't something that really put our system over the edge, and that's actually the best kind of disaster to have, because now the next time will just be that much better. So it also highlighted the fact that we need to do more drilling, and I think that hopefully this will be sort of an impetus to push our leadership and our legislatures to really move forward in that direction. Thank you.
Thank you.
Any other questions from the audience? Dr. McCursey.
Bob McCursey, I'm a fellow surgeon. I want to shift gears a little bit. Since this is a quality forum, I'm going to ask a question about quality. We've got trauma centers, we've got trauma systems. They work increasingly through some of the college programs to use Dr. Hoyt's words, measurably improve care, deliver better outcomes. Against that background, and with an interest, expressed interest in all this pay for performance, payers we've got, government agencies that are willing to pay for this. One, we've got measurably, programs that measurably improve outcomes on the other. How do we leverage that? How do we leverage the interest in pay for performance with the measurably improved outcomes that trauma centers and trauma systems provide in order to fund the enterprise and drive it towards further improvement?
Thank you, Dr. McCursey. Dr. McCursey was one of my previous partners, so.
Excellent question.
You know, we could, as I said earlier, we could spend a half day talking about costs, because we're talking about quality today, but cost is really what's driving a lot of the initiatives. And there is a way to bring the two together, though. And the basis of quality is really to try and do things the correct way the first time, avoid complications, have consistency in the way in which you do things, and through that, lower cost. So when you have a quality improvement program and you're willing to sort of defend that quality improvement program and say that through that quality improvement you will in fact reduce complications, and then you're willing to take some of that risk financially. What that does is two things. One is it frees up dollars, so your costs actually go down, and you can then take those dollars and turn them into incentives for the providers to encourage them to participate. And so the policy behind a lot of the payment methodologies that you're seeing come forth from Congress right now are basically linked to that. The devil's in the details, and it's really hard to decide which one's going to work. But the principle is to link payment in the future to quality improvement based on measurement. It's really what the whole ACA law is about, is creating transparency of price and creating transparency over performance. And if you incentivize those and link the two together, you should improve the system. And so I think, you know, we have a lot of hope about that, Bob, and that this is actually something that's doable, but, you know, it's going to really take another 10 years to figure that out, I think.
So this incident was an airline crash similar to a bombing where there's no risk to the medical personnel. And so the literature will show that you'll get 100% response of your staff showing up, even more than 100%, as one of you said. There were too many doctors and nurses coming to the site. But at the other side of the spectrum is something like an earthquake or a typhoon, where medical personnel are part of the complex, the victim complex, and we can expect upwards of 30% of our team not to show up to an event, and then as the days go on, that attrition rate will get bigger and bigger. So more of our team won't be medically trained. So how do we prepare for a surgical team that's made up of 40% non-trained personnel?
I think the Missouri tornado was a good example of what happened, where the hospital was destroyed. And we addressed that a little bit last year at Fleet Week, and actually had the portable hospitals brought in on the bay and set up, so that we saw how long it would take for a complete hospital set up to come into San Francisco in the event of an earthquake, where San Francisco General would be destroyed, as well as many other hospitals, although we are having a new hospital open, which is supposed to be earthquaked. But our offices will still be in the old building, so we'll be dead. But the hospital. But anyway, we talked about that, because that's a very, very real concern, is how are you going to provide within your, and that's a real disaster, right? A real disaster overwhelms the system that's in place. This was actually not, it was a disaster, but not so much that we couldn't handle it. In fact, we could have handled more patients. But I think we have to look, that's where I think there's a value in continuing our collaboration with the military and continuing to train for disasters with them, because we're going to need that kind of team brought in who's ready. And the hospitals that come in are the MASH hospitals that have been deployed during the war. Everything's ready to go. They can come in by water. They don't have to come in by airplane if the airfields are down. And with the one that was set up in Missouri, I think a full hospital structure took them about 5 days to set up after the tornado that went through there.
Any additional questions? If not, I think it's time to thank everyone so much for coming and spending your time this morning devoted to this exceptionally important topic. Thank you all.